Hey guys, okay, so we're gonna do chapter 15 and 16 today. So we're gonna go over cystic fibrosis and bronchiectasis together and get these posted for you guys to do your summary. And then you will be able to do your quiz once I get that posted, which will probably be tomorrow or today. I don't know if it'll be today, it's kind of getting late. I got lost here. Give me a second. Okay, there that is. Okay. Hold on a second. Sorry. Okay, so as we see here, you got cystic fibrosis. I'm just going to kind of just show you a little thin layer of mucus. This is a normal cross-section of an airway. This is what it would look like with cystic fibrosis, okay? Here's his sinuses, here's his lung, his skin. This messes with their liver and their pancreas, okay? And their intestines. So don't just think that this is having to do with the lungs. It'll eventually move into their intestines. So it does get a little bit worse. So our anatomic alterations, we have excessive production of thick tenacious mucus in the tracheobronchial tree, and then partial obstruction of mucus plugging, and hyperinflation of alveoli, total bronchial obstruction, mucus plugging, atelectasis. And then we're looking at our cross-sectional here. I really, when you guys do your disease presentations, it's very important that you include these, okay? It says it in the breakdown. When I say your breakdown, you have your, you should have your not algorithm, you should have your, darn it, your grading a sheet, and it's good for us to see these. You can find them in the book, you can find them on Evolve. It's good to see a cross-sectional. We like to see that so you understand a little bit better. So you're looking at here, you're seeing the mucus accumulation, okay? Mucus plugging, the mucus plugging is going to cause that atelectasis, okay, to develop. And then you got hyperinflation of the alveoli, okay? And of course, we've got the partial obstruction of the airways, which could cause that hyperinflation of the alveoli. So don't ever forget about that. You know, so all those CF patients, and like at birth, their lungs are normal at birth. Abnormal obstructions can develop quickly, so they can start seeing stuff soon after birth. It may result both as restrictive and obstructive. Remember, I've talked about this. Even though they're obstructive patients, we can see them become restrictive because look what happens with that mucus accumulation coming in here. You got this out here, and then it's coming in here, and it's coming in, and it's causing mucus plugging. So what happens is it's going to cause atelectasis, and atelectasis is going to cause restriction, right? It also could cause pneumothoraxes. It can cause anything. It causes destruction of the alveoli. So all that can cause your patient to become a little bit restricted at times. Excessive secretion, bronchial obstruction, and hyperinflation of the lungs are predominant features of advanced stages of CF. My slides don't want to go nowhere. Uh-oh. I probably went too crazy with my stuff. So let's stop and think about this a little minute. I thought I was going to do this in the actual class, so I'm not. Okay, so we have a stagnant mucus found in a CF in the tracheobronchial tree, so it serves as an excellent culture. So if we're going to take a culture from a CF in the tracheobronchial tree, so, you know, that's going to be down, you know, in our tree, so that's going to be all the little bronchioles. It's not going to be up or high, right? So this is going to be down low. This tree serves as an excellent culture medium for which of the following bacteria? So we have Pseudomonas aeruginosus, right? Mycobacterium tuberculosis, Staphylococcus aureus, and Haemophilus influenzae. Okay, so first off, let's think about process of elimination. Okay, I always like to do this. I think this is the best way to try to teach you guys how to take your boards, how to understand questions, and think about stuff. So give me just a second. I'm cold. Okay, so first off, we know Pseudomonas can tend to have bacteria, right? It grows bacteria. It's probably gonna be a good answer. Okay, so we're gonna say yes to that one, right? Okay, so yes to Pseudomonas. Okay, let's go with that one. So let's go with Pseudomonas, right? Ooh, it's not one highlight. Okay. Um, let's think about tuberculosis. Would tuberculosis be found in our tracheobronchial tree? We haven't went through tuberculosis yet, and Mycobacterium tuberculosis is tuberculosis. TB. Okay, so when we get to TB, TB is found usually in your upper origins of your. It's really weird. It's not found down in your bases. It's found in your upper base. I mean, your upper airway, not your upper airway, but your upper lobes, okay? Not in your bases, okay? So you will find circular Mycobacterium tuberculosis upper, okay? So it's usually not found in the lower, and it's also usually in its own, okay? So would that stagnant mucus be found in a CF tracheobronchial tree? So let's say that's a no, right? So if we're saying it's down in the tracheobronchial tree, we can rule out Mycobacterium. So we're going to say no to that, right? Process elimination. Staphylococcus aureus. You don't know a lot about these cultures, but you know enough that we've talked about them. These usually get cultured from most of our patients. So I'm going to go with yes, okay? And Haemophilus influenzae all the time. So 1, 3, and 4 are our best options. So I think you could get this very easily as we go through, okay? So these are the best options. You know that tuberculosis is a no-no, okay? So we don't pick that one. It does not fit in the equation, so you take it out. I hope I can take this out, actually. Oh, we're at race. Oh, okay, good. All right, so back to our arrow options. Oh, so etiology and epidemiology. So most common fatal inherited disorder in childhood, it is. Okay, so we need to know that. It's very important. We're talking about this. And it's autosomal recessive gene disorder caused by mutations in a pair of genes located in chromosome 7. So you have a lot of disorders that can be inherited, and talk about chromosomes. This happens to be one of them. Over 1,700 different mutations in that gene that encodes for cystic fibrosis, transmembrane conductance regulator, so CFTR. So that's a CFTR membrane. The abnormal expression, I need to make this, sorry. Okay, so the abnormal expression of that CFTR results in abnormal transport of sodium and chloride ions across many types of the epithelial surfaces. So results in thick, vicious mucus accumulation in the lungs, and mucus blocks the passageways of the pancreas, preventing enzymes from the pancreas from reaching the intestines. I got a little crazy with my stuff. Okay, so let's look at these two little images right here. I know they are kind of difficult to understand, but we're going to kind of review them. Okay, so let me move my face. My face is in the way. Okay, so abnormalities in the CFTR protein prevent chloride flux in the airway epithelium, resulting in an abnormal reabsorption of water, creating thick mucus and adequate mucociliary function. So A would be chloride channel defect in the sweat duct causing increased chloride and sodium concentrate in sweat. So if you're looking at A, you see where chloride and your sodium is coming in, and that's normal. And then you have a lumen of sweat duct, and then you have cystic fibrosis where your chloride's being blocked, okay? So, and the sodium is just completely not happening, okay? The chloride's not coming in, and your sodium's just being turned out, okay? So that means that on the outside of that sweat duct, your sodium's coming out and it's just staying out. So you're gonna have a lot of sweet, salty skin, okay? So in the airway on B, patients with CF have decreased chloride secretions and increased sodium and water reabsorption. So it's going to have a lot of sodium and water absorption. So leading to dehydration. So dehydration, okay, a mucus layer coating epithelial cells and defective mucociliary action and mucus plugging of the airways. So it leads to that CFTR regulator and an ENAC epithelial sodium channel. So look at that B, you see that normal mucus supposed to come in, and we have that chloride and sodium and water uptake. But see that dehydrated mucus is real thick and real dark. It looks like it's just so accumulated. It's just not working out for them. This too, so you have your mutation classification, so a basis for categorizing CFTR. The red balloon, okay, the red balloon-like icon above represents the CFTR mutations. So the red balloon, so you have a normal chromosome, and it is coming, and then there's your protein, and it comes out, and then you've got chloride. And then class 1, this one stops. Class 2, protein defect, it blocks it. Then you have your gating effect and conductance effect and limited quantities and accelerated turnover. So 1, 2, 3, 4, 5, 6, wait, 3, there's 7 of them, okay? 7 mutations. So you have your molecular defect, no protein, no CFTR traffic, no function, less functional protein, less stable protein, and so on. So our 6 classes of CFTR mutations are divided into 3 broad categories. So affecting the quantity of the CFTR protein and affecting the function of CFTR protein. Also classified as either a gating defect, like I just spoke about, which is a class 3 where the channel does not open, and a conductance effect, which is class 4 where the channel is open but chloride decides not to move efficiently. So how is this cystic fibrosis gene inherited? Okay. It is a recessive disorder. It's a recessive disorder, and the child must inherit 2 copies of the defective CF gene to have the disease, one from each parent, cystic fibrosis carriers. So if both parents carry the CF gene, the possibility of their children having CF follows the standard Mendelian pattern, and estimated that more than 10 million Americans are unknowing symptomless carriers of the mutant CF gene. So there is a 25% chance that each child will have a CF, a 25% that each child will be completely normal and not carry the gene, and a 50% chance that each child will be a carrier. So you have a recessive gene disorder, and then the child must inherit 2 copies of the defective CF gene to have the disease. So one from each parent, okay? So one's going to come from each parent. And if both parents carry the CF gene, they both have it. The possibility of their children have a CF follows the standard Mendelian pattern. So there's estimated more than 10 million Americans are unknowing that have this. So there's the 25% chance, once again, we're going to go through this chart in here in just a minute. That's going to help you a lot more. That each child will have CF, and then there's a 25% chance that each child will be completely normal and not carry the gene. And then there could be a 50% chance that each child would be a carrier. Okay, so let's look at this chart. Okay, this usually helps everybody. So we have the red and the blue, right? So if you turn to page 15.4, okay, this is the Mendelian pattern of inheritance of cystic fibrosis. So red is a non-carrier parent, blue is a carrier parent. So we're going to look at this. So a genetic pattern in the CF gene, the child must inherit 2 copies of the defective CF gene, one from each parent. Although the carrier can be identified through the genetic testing, the carrier does not demonstrate evidence of the disease. If both are carriers, there is a 25% chance each child will have that CF, 25% they'll be normal, and 50% they will be a carrier. And there's about 30,000 adults and children in the U.S. that are living with CF, and greater than 90% are diagnosed during newborn screening. And life expectancy is usually in their 30s, but some can live to 40% and beyond, and this is found in 1 in 3,000 Caucasians. So let's look at this chart. So you have your red's a non-carrier, blue's a carrier. So we look in the top left-hand corner right here, and so we have this one. So this one's half, so it's 50-50, right? And 50-50. Oh, I don't know why it's doing that. So this one's 50 and this one's 50, okay? He's half and she's half. So this one means that this kid has 25% chance of unaffected. This kid probably has a 50% chance of unaffected carrier. This one has a chance of being unaffected. So that means it also has a 50% chance of being affected, and this one has 25% chance of being affected. Okay, so that's this group. This one's 50. I don't know why it's doing that. And this one is 100%, okay? This is a CF parent, okay? So that leaves this one with, these are 50% chance not being affected. But this means you have 4 kids, okay? Usually, a CF parent usually tends to, I don't know, they usually don't have kids. We'll talk about that in a minute. The female might can, not usually do they because they're so weak, but they could. Okay, so you have a 50% chance of being affected. So if you have 2 kids, you're probably going to have one that's going to have it, okay? So here you got a 50% chance of not, 50% chance of. So here we go again. This one's 100. What is it? Okay, that's weird. 100%. And this one's 0, okay? 0%, okay? So that means that all of these are 100% chance unaffected carrier, if you look at it like that. So this one's 25, 25, 25, 25. So there's a chance one of this probably, when I say 50, I guess it's a 50% chance one of them's going to have it, okay? So, again, this one's going to be a 25% chance. This one is a carrier, and this one's not a carrier. So then you have 50% chance unaffected, 50% chance unaffected or affected, okay? So that's how you look at that. So hopefully that helps. And I'm not sure what I did to my slide. So you just got to go back and look at that. And all right, so your screening and diagnosis. They're based on the clinical manifestations associated with CF. So you have a family history, you have your laboratory findings, you have 2 criteria that must be met to diagnose CF, okay? You, number 1, clinical symptoms consistent with CF in at least one organ system, such as your pulmonary system, your sinus system, your pancreatic disease, your meconium ileus, your biliary disease, and your male infertility. That's the thing. Oops, look at me. Okay, male infertility, that's what we're going to talk about. Usually if it's a male, they're usually infertile, I mean. They cannot have kids, okay? Number 2, clinical evidence of cystic fibrosis is the CFTR dysfunction has to be met. So these have got to be met to diagnose the patient. So clinical evidence of cystic fibrosis, an elevated sweat test. Okay, I don't know if we talked about this before, but a baby kid will usually show symptoms, and we will do a sweat test. So it's called an elevated sweat chloride greater than 60 milliquats per liter on 2 occasions. You can't just have it once, you got to have it twice. Molecular, so let me talk about the sweat test. So the sweat test is reliable for about 98% of patients with CF. So you have your molecular diagnosis genetic testing also, and presence of 2 diseases causing mutations in CFTR, an abnormal nasal potential difference. I thought I had, don't get me wrong. Okay, sorry. So newborn screening has been a part of the newborn genetic testing protocol in all 50 states since 2011. If you get to go up in the NICU, you might get to see them do all this. They're not going to do a sweat test unless they think the patient has CF. They won't do that. But they'll do all this newborn screening. But most infants with CF have an elevated blood level. It'll come back with immunoreactive trypsin. So it's an IRT. So they run IRTs. It's measured from the blood dots collected on a newborn infant on a Guthrie card. So what they do is they'll take blood from your baby and they smear it on a Guthrie card, and it's turned into the state or to, I guess it is the state, or maybe it's just to the health district, and they run that test and they bring it back. So all families and infants as identified through the newborn screening program should receive genetic counseling. So if we found out that we would have to talk to the family. Obviously, this is a big thing. Like if you didn't know your baby was going to have cystic fibrosis and all of a sudden you found out, think of the heartache you would have. It's a lot to put on somebody. That's a lot. A lot of these people have to stay home with their kids whenever they weren't planning on that. It's a big loss. And, then thinking that your kid's not going to live past a certain age, and the management and the lifestyle change that they're going to have and so forth. So back to the sweat test. I was trying to, okay. Is the gold standard. Okay, I talk about the gold standards. This is the gold standard diagnostic test for CF. It's a reliable test for identification, like I said, of 98% of patients with CF. It measures about amount of sodium and chloride, a patient's sweat. Pilocorpine is applied to the patient's arm or leg. So during this procedure, a small amount of colorless, odorless, sweat-producing chemical called pilocorpine is applied to the patient's arm or leg. It's usually the forearm that they're going to put this on, and it's an electrode is attached to the chemically prepared area, and a small electric current is applied to stimulate sweat production. And the test is usually done twice. And so this is kind of what it looks like. They just kind of have this little thing and they do a test, and it's nothing too crazy about it. So like I said, it was 60 milliquats per liter is a diagnostic sign. The sweat glands of the patient with CF are microscopically normal. The glands secrete up to 4 times the normal amount of sodium and chloride. And so greater than 60 milliquats, that's your gold number. And any of the clinical symptoms or signs should have a sweat test or infant with positive newborn CF screening. So if it comes back with that, also if you're looking at an infant with positive signs suggestive of a CF or older sibling, with symptoms suggestive of CF, or any members of the patient's family with confirmed CF. So if you know that they have CF, you're going to test your baby for CF. If they're positive with that newborn screening that's performed after 2 weeks of age and greater than 2 kilograms of asymptomatic, you're going to get them tested. You also, if you happen to lift your baby up, it's one thing Mr. Henson always told me. You lift that baby up, and all of a sudden, you smell that baby, and you feel that baby has had kind of taste, kind of salty or something like that. That's definitely going to tell you that that baby could possibly have CF. If they're constantly tasting a little sweet or salty, that is a sign. Infants 6 months or younger, so less than or equal to 29 millimoles per liter is normal cystic fibrosis. It's very unlikely. You have 30 to 59 millimoles per liter is intermediate. It's possible cystic fibrosis, and it's greater or equal to 60 millimoles per liter is abnormal diagnosis of cystic fibrosis. So infants older than 6 months, children and adults, it's got kind of same. See, that's 29. This is 39. It jumps up by 10. Okay, so but the 60 stays the same. So you're really not changing anything. It's just looking like that the 10 kind of goes up. It's not where we start with a normal. Okay. So clinical indicators justifying the evaluation of CF. So I've talked about this a while ago. You got the pulmonary, wheezing, chronic cough, sputum production, frequent respiratory infections, abnormal chest x-ray, and CT, and nasal polyps. They get nasal polyps, and peritonitis, and digital clubbing, and gastrointestinal disorders, and failure to thrive. The babies will sometimes have that failure to thrive, so you also would get them tested or take them to the pediatrician and maybe send. And foul smelling greasy stools, and voracious appetite, and milk and formula intolerance, and rectal prolapse, and meconium ileus. So meconium ileus is actually, meconium means that actually comes from their stool, and ileus is down around their rectum. And meconium peritonitis, same. So distal intestinal obstruction syndrome, pancreatic insufficiency, pancreatitis, hepatobiliary, hepatomegaly. They have a lot of liver and kidney problems. Focal biliary cirrhosis, prolonged neonatal jaundice, cholelithiasis, nutritional deficits, fat soluble vitamin deficiency, vitamin A, D, E, and K. So they need to stay on vitamins and eat a healthy diet. Hypoproteinemia, hypochloremia, and infertility, like I said, and obstructive azoospermia. So let's just think a couple is considering having children. She is genetically tested and finds that she is a carrier for the CF gene. What should the healthcare provider recommend? Technically, we want to make sure that the father is being tested as well, because the father is a carrier, then there's most definitely their child's probably going to have CF. So it's probably not a good idea to have a kid if he's the carrier, if she has CF, because 75% chance is probably going to have CF. That's probably how you need to look at it. A sweat chloride test is done on an infant, and the results are 72 millimoles per liter. This signifies which of the following. If we go back and look, remember what I told you? It's 60, right? So CF is likely a definite factor. So another way to test them is molecular diagnosis testing. And it is with a sample of patient's blood or cheek cells, a genetic test can be formed to analyze DNA for the presence of the CFTR gene mutations. It's also called a genotype testing, and it can be formed to analyze the DNA. Intermediate results of sweat chloride testing should be further investigated with DNA analysis, and the sweat test should be repeated as well. Then you have nasal potential difference. It can be measured with surface electrode over the nasal epithelial cells lining the inferior turbinate. It can be recommended for those who have borderline or normal sweat tests. The impaired transport of a sodium and chloride across the epithelial cells lining the airways of the CF patient can be measured. The sodium and chloride ions move across the epithelial cell membrane. They generate what is called the electrical potential difference, and that's what's called that. So we have prenatal testing as well. Well, you could find out from there. Both the American College Obstetrics, sorry, I can't talk today, and Gynecology and the American College of Medical Genetics recommend that pregnant women, females, be offered screening for CF mutations using the 3285 mutation panel. Females who test positive for CH mutation then have the option of having the father of the fetus tested. And if both parents are positive for the CF mutation, the fetus has a 1 in 4 chance of having CF. So you can do an amniocentesis, which would be recommended if this is to test at the first of the third trimester. Diagnosis is a large number of genetic disorders and chromosomal abnormalities in the fetus. The only thing that an amnio could cause is possibly, number one, maybe a pneumonia. Maybe it could also cause the baby to abort. Genetic counseling, obviously we would suggest that because all causes of prenatal testing for CF is explained the uncertainty of residual risk to the prospective parents. So you have a stool fecal fat test. It measures the amount of fat in the infant stool and percentage of dietary fat that is not absorbed by the body. And it's used to evaluate how the liver, the gallbladder, pancreas, and intestines are functioning. And infants with CF and pancreatic insufficiency will have a fecal elastance of less than 50 micrograms of stool, and normal is greater than 300 micrograms of stool. So, I guess I messed up on that. So overview of the cardiopulmonary symptoms can be related to this. So atelectasis, bronchospasm, and excessive bronchial secretions. What is happening here? Okay, so physical exam, you have increased, obviously, tachypnea, tachycardia, blood pressure, use of accessory muscles on inspiration, use of accessory muscles on expiration, pursed lip breathing, increased AP chest iron number. So they're going to have a barrel chest. I don't know why it's like that. Cyanosis and cough, digital clubbing, cough, sputum production, and hemoptysis. And our chest assessment findings, we're going to have a decreased tactile and vocal fremitus, because obviously if we have a lot of secretions, we're going to have it compacted like that. Hyperresonant percussion note, diminished breath sounds, diminished heart sounds, bronchial breath sounds over atelectasis. We could have crackles when there's a lot of fluid, wheezing, spontaneous pneumothorax, because that can happen because we're having a lot of mucus plugging, a lot of hyperinflation of the villi. Here is our severe cystic fibrosis. We have a FEVC that's reduced, FEV. So we're in a severe cystic fibrosis. We're obstructed. Once again, our gases, obviously, we're going to be right here. This is going to be our acute respiratory alkalosis. And then chronic vent failure. because they're compensated respiratory acidosis, and they have acute alveolar hyperventilation superimposed on chronic vent failure, so possible impending acute vent failure. And their oxygen indices, and CBP, RAP, PAP, and PCWP. So abnormal lab tests and procedures. So your hematology, you're going to have increased hematocrit and hemoglobin because they could be polycythemic. Increased white blood cell counts because they have a lot of infections. Electrolytes, because that's important because remember they have hypokalemia, so chronic vent failure. Increased serum bicarb, chronic vent failure. Sputum exam, gram-positive bacteria. So we talked about this earlier. Staphylococcus aureus, Haemophilus influenzae, gram-negative bacteria. They're going to have Pseudomonas aeruginosus, Stenotrophomonas maltophilia, and Burkholderia sepicea complex. So in our x-rays, we're going to see transluent dark lung fields, depressed or flattened diaphragms, right ventricular enlargement, areas of atelectasis and fibrosis, tram tracks, we'll talk about that. Bronchiectasis, it's often a secondary complication, meaning that your patient can go from CF and turn into a bronchiectasis stage. Pneumothorax, which is spontaneous. Abscess formation, so it could cause an abscess because of all the secretions. So here, you're going to see a chest x-ray of a patient with CF. He has lung overinflation. The diffuse infiltrates. A large main pulmonary artery segment reflecting pulmonary hypertension. Then you have cystic fibrosis, serial chest imaging over a 26-year period showing a progressive changes of cystic fibrosis. So A is at age 3, okay? The patient had a right middle lobe pneumonia. Okay, so we're looking at right. So this is our left and this is our right, okay? And so he had a right middle lobe pneumonia. Let's see. See something in here. Okay. And B, he had, yeah, okay. Where are you? Right here. So B, he had mild hyperinflation and bronchial wall thickening. So you can see those bronchial walls thickening right here at age 7. And then at C, he's 15 years old, and the patient demonstrated progressive hyperinflation, bronchiectasis and enlargement of the hyla on the chest x-ray. So, yes, okay, so enlargement. Okay, so he has progressive hyperinflation. We can see a hyperinflation of the lungs, enlargement of the hyla, and bronchiectasis. So you're going to see destruction and demonstrated progressive hyperinflation. And then at 29, he looked at his barrel chest. Typical findings of end-stage cystic fibrosis. Note the hyperinflation, barrel chest, deformity, severe bronchiectasis, tubular opacities. So you kind of can see the tubular opacities throughout here, and consistent with mucus plugging, you can see mucus plugging throughout. Common non-respiratory symptoms, you have the distal intestinal obstructive syndrome, malnutrition and poor body development, so they need vitamin A, D, and E and K, nasal polyps, and sinusitis, so that's seen in 10 to 30% of CF patients, so causes nasal obstruction and distortion of facial features. So 90 to 100% sinusitis. So Back up to the malnutrition. They really malnutrition because of all the work they're doing and the pancreatic ducts becoming plugged with mucus. So it inhibits digestion of the protein and fat, and 80% CF will have that vitamin deficiency. And let's see, infertility, 99% are sterile, males are. Women may not carry to term. If they do, their child will have a CF or will be CF or be a carrier, okay? So they really tried to persuade them not to have children. General management of CF, okay, so let me go. I didn't say this, sorry. It didn't say it here, okay. Well, let's talk about it. So meconium ileus, we talked about that earlier. They have obstruction of the small intestine of the newborn that is caused by impaction of thick, dry, tenacious meconium. So meconium is, we'll talk about it because you're going to have meconium babies and we'll have a meconium come up through this disease thing. That's meconium is the first stool and all that stuff that comes out, okay? It's an obstruction of the small intestine of the newborn that is caused by impaction of thick, dry, tenacious meconium. It's usually at or near the ileocecal valve. It's suspected in newborns who demonstrate abdominal distension and fail to pass meconium within 12 hours after birth. So usually baby's supposed to poop as soon as they come out, okay? So if they hold it, then they can cause an obstruction in their ileus. So that's what that is. So in a meconium ileus that is equivalent occurs in older children and young adults as well, okay? So general management, the primary goals are to prevent pulmonary infections, reduce the amount of thick bronchial secretions, improve airflow, and provide adequate nutrition. The patient and the patient's family should be instructed regardless of the disease in a way to affect body functions. Okay, so bronchial hygiene. Okay, yeah. Oxygen therapy. Obviously, we're going to supplement for that. Airway clearance therapy, lung expansion therapy, which is airway clearance. So bronchial hygiene, we're going to do at least 2 times a day, 20 to 30 minutes. So manual CPT, okay, or and postural drainage. If they have a mechanical CPT, which most of them do, they need to be doing that 2 times a day, 20 to 30 minutes. If not, then somebody needs to be doing CPT on them. Most of them all have a vest at home. Lung expansion, they should be doing deep breathing and effective cough. If not, they need some type of PEP therapy. This is mandatory for them. They all get this kind of treatment. Meds that are recommended for our patients here, these are all important information, you guys. You need to know this. So recommended is a beta-2 adrenergic agent, which is albuterol, salmeterol, formoterol. Also, sometimes we'll give them Atrovent, but it's just, it depends. That's our bronchodilators. So our mucolytic agents, pulmazine. This is a actual, we'll call that when we get in more into your drugs. They have certain drugs that are named for each, some disorders. And this is for them. This is only for them. It's pulmazine, which is called Dornase alpha. So you'll see it as DNASE, Dornase alpha, or pulmazine, okay? Pulmazine is the actual brand name. Dornase alpha is the generic name, okay? It's inhaled. It's for them. It's for their, it helps them with breaking down their mucolytic barrier. We'll talk about that in a minute. It's been especially helpful in the management of patients with moderate to severe CF. It is an enzyme that breaks down DNA of thick bronchial mucus associated with chronic bacterial infections. They can get inhaled hypertonic saline to help get that out. And sometimes they'll prescribe them mucomist as well. But they're usually, pulmazine is every day. It's constant. Mucomist is as needed basis, you know, when they have an infection. So mechanical ventilation protocol. BiPAP is preferred before intubation. We always want to try that. That's really their protocol as far as that goes. let's do that. And as usual, that's how we would treat that. So this little girl, she's so cute. Okay, so this is an 18-month-old little girl with CF. She's wearing a high-frequency chest wall compression vest, and it's called the Encourage system. And today it is commonly used for bronchopulmonary hygiene treatment for airway clearance in patients with cystic fibrosis. They can get these now, and they can get them all dolled up. I'm pretty sure if she wanted Paw Patrol or some kind of girl cartoon or whatever she wanted on it, she probably could get it. They have them made up like that now. So once again, let's talk about Dornase alpha. So in this picture, you will see A is going to be, so this is illustrated the mode of action of Dornase alpha in reducing DNA polymers and CF sputum. So confocal micrograph showing CF sputum stains. So for DNA before and after a treatment. So before, here is your sputum that our CF patient's producing. B is the breakdown after the treatment, what it did to that thick sputum. So that's what that pulmozyme is doing. So without that pulmozyme, we could really cause some damage for our CF patients. They really need it. It helps keep those mucus plugging down, probably some infections down. It's a Dornase alpha in vitro, so the long DNA polymers are degraded into short units after Dornase treatment. So other medications and special procedures by the patient, by the physician are corrector drugs which help mutate CFTR, reach the epithelial cell surface where the CFTR protein normally functions as a transmembrane regulator of chloride movement out of the cell and sodium transport into the cell. Potentiators, drugs which help mutated CFTR function more effectively at the epithelial cell surface, transporting chloride out of the cell and inhibiting the movement of sodium into the cell. And we have antibiotics, ibuprofen, inhaled corticosteroids, and systemic glucocorticosteroids, and longer heart lung transplant. So sometimes they have to do both, and some just do lung. But the success rate of lung, over 90% CF are alive at least 1 year after transplantation, and 80% are alive after 5 years. So remember that it's probably growing. Because remember, the books are a few years behind, so it's improving all the time. So things are getting better, and it will continue to do that. So I know these CF kids are starting to get older and older as time goes and progresses. All right.